Iowa, and today I'd like to talk about a topic that I think is both very important to me and hopefully will help you in your practice as well. I have no financial relationships regarding this lecture. I have several objectives today. First off, I'd like to discuss the epidemiology of pediatric cancer-related effects. I'd like to describe a risk-based approach that you can use when evaluating these patients. I'm going to talk about mortality and secondary malignancies. I'm going to go through a systems-based review of toxicities focusing on the primary areas that I see morbidity and mortality. And then we'll talk about some interventions and management strategies that you can use as well in the primary care clinic as well as a specialist. And then I'd like to briefly describe the Blank Children's Hospital Late Effects Clinic and what we do there. So to start off, to orient ourselves, pediatric cancers are quite diverse. The most common cancers are leukemias, followed by brain tumors. So these will be the two patient populations that you will see the most of in long-term follow-up. Pediatric cancer is also very curable in this day and age. I really enjoy looking at this slide. So the green line here shows the progress that we've made in all pediatric cancers in terms of survival over the years, and this yellow line here in particular shows our steady improvement in survival in pediatric leukemia. So we've definitely made some progress over the last several decades. And I always enjoy looking at this ALL slide, looking back in the late 1960s and early 1970s up to present day. As you can see, the survival has improved markedly in the long term. There are approximately 13,000 new pediatric cancer diagnoses each year, and right now our overall survival is approaching 80%. Our main goals are, of course, to maximize this cure rate, but also to minimize toxicity. And unfortunately, sometimes cure does come at a great price. This is a growing population, as you might expect then, and actually the majority are adults at this point. And 1 out of every 650 patients or so is between the ages of 20 and 39. And these late effects can also be quite diverse as well. They can be physical, psychological, and they can occur shortly after therapy or quite a bit down the road. And they're defined as these effects that occur 5 years from diagnosis. And another important point to bring up is that most survivors do receive care from their primary care physician. There is a gravitation that occurs from the oncology community out back into the general practitioner realm. So late effects are actually pretty common. There's about 270,000 childhood cancer survivors in America today, and about 3/4 of these will have a chronic disease by age 40. 2/3 will have at least one late effect. Half will have moderate to extremely diminished health status, and 40% can actually have a serious health problem. And then kind of the tip of the iceberg here, 1 out of 4 will have a severe or life-threatening late effect. We talked about the fact that there are risks for secondary cancers, organ dysfunction, but also growth and developmental problems, fertility issues, neurocognitive issues, and as well as in the psychosocial realm, so employment, insurance problems, and reduced quality of life. So sadly, only about 72% of survivors can actually even name their diagnosis. 32% had a cancer-related doctor visit, and this is likely to decrease as time progresses. And most of these survivors are not followed at a cancer center and by their PCP. 27% only had one within the last 2 years. 23% have a cancer treatment summary in their possession. And what's probably the most unfortunate aspect is patients are unaware of their risk, as you might imagine. 35% of survivors understand that treatment could result in serious health problems, meaning the majority do not understand that they're at risk for severe long-term consequences. Now, the primary care physician sees on average less than 5 childhood cancer survivors per year. I think most of you probably see 5 patients before breakfast in the morning, I think, in the busy clinics that we see. So my goal today is to give you the tools and the resources necessary to best take care of these patients. We're going to talk about risk-based healthcare and working together with us as well in the oncology clinic. There are a number of factors to weigh in this risk-based approach. And so you've got your treatment factors. So the duration since treatment is important to know, the types of treatment as well as their dose and intensity. The intercurrence of treatments is also critical, and being aware of their prior treatment toxicities as making them a risk for future treatment toxicities. There are also individual factors that play a role as well: the patient's age and the age at the time of therapy, their development, their gender, and in fact most of these light effects, as you'll see, are more severe in females. There are genetic predisposition variables, and actually we're learning a great deal more about this. There are health behavior habits and other comorbidities that play a role. We'd like to take a word to talk about the Childhood Cancer Survivorship Study, and I'll be referencing this data throughout my talk today. This is a multi-center study, and it's a pediatric retrospective cohort study, and this is probably the largest body of data available today in the world regarding pediatric cancer survivorship. St. Jude's has taken the lead on this and involved all these institutions, and it's looked at almost half of the 5-year survivors of pediatric cancer between 1970 and 1986, over 14,000 patients, and even as importantly, almost 4,000 siblings as a reference group. This body of data encompasses a great deal of diseases and treatment modalities. And actually all the raw data is available at that website that I have referenced here. And at the end of my talk on your handout, I've actually compiled all the resources and websites in one area, so that'll be for your reference as well. There are some limitations to research in this field, in that much of the data is self-report and thus inherently susceptible to bias. There is a retrospective nature to this, and there's also a great deal of variability in the way late effects are measured. Also, a problem that's impossible to do away with is that long-term data may not apply to current treatments. By nature, there's anywhere from 5 to 30-year lag time in this data, so certainly may not be reflective of what's actively going on. And the big area, the big question mark, is that there's limited and emerging data on the efficacy of interventions. So we know the problems, but we don't know if we're doing the best job of fixing them. So in general, survivors have increased mortality. And so up here we see the normal overall survival for U.S. males and females. And as you see here, there is quite a big gap between cancer survivors and the normal population. Now, most premature deaths, in particular the first few years, are due to late relapse. The majority of problems occur from treatment-associated second cancers and major organ toxicity. So I'm going to focus on these major causes of death and morbidity. So second, neoplasms. So we give a lot of drugs that fortunately are very good at damaging cancer DNA, but also very good at damaging healthy DNA. We give alkylators like cyclophosphamide, we give topoisomerase inhibitors like etoposide, and we give radiation therapy to these patients. And so, as you see here on the right, this is the mechanism of action. Mechlorethamine, otherwise known as nitrogen mustard, is kind of the building block for many of these drugs. And once they cross-link this DNA, they can set it up for abnormal repair and can cause second cancers. The primary cancers that we see most commonly associated with secondary neoplasms are Hodgkin's lymphoma, Ewing sarcoma, brain tumors, and AML. Second neoplasms are the leading cause of treatment-related mortality in the Childhood Cancer Survivorship Study, which we just talked about, accounting for 60% of treatment-related deaths. I'm not going to focus on it too much, but there's also quite a high incidence of non-melanoma skin cancers, up to over 9% by 30 years. And in Hodgkin's populations, this is quite high at 21% incidence. So as you see here, there seems to be kind of no end in sight, at least for secondary cancers. Any secondary neoplasm approaches about 20% incidence by the time you get to 30 years out. We see here, however, secondary malignant neoplasms, not including non-melanoma skin cancers, which you see here, approach close to 9% incidence. When we look at the data from the Childhood Cancer Survivorship study, about 1,400 patients developed 2,700 cancers. The excess risk was 2.5 per 1,000 person years, and probably a very important point to note is that the mean age of diagnosis was about 30 years. So, many of the topics today are, outside of the pediatric realm at this point. Second neoplasms are the most common cause of late mortality, so after 20 years post-therapy, this is the #1 cause of mortality. So what are the variables associated with these? And in the multivariate analysis, and as will be a common theme throughout my talk, radiotherapy is not good. This was associated with a 2.6 relative risk actually for developing a secondary malignant neoplasm. Hodgkin's therapy also is notorious for being associated with secondary cancers. Age greater than 15 at primary diagnosis, and female gender also. I guess what the positive of this would be is that with each subsequent treatment group in terms of time of treatment, there's actually a protective factor almost. So hopefully this means that with each new era of treatment, we're going to decrease this risk over time. So as I mentioned, certain cancers are really setups for developing second neoplasm. So the blue bar shows the percent of patients in the survivorship study that had this particular primary neoplasm, and then the red bar showed the standardized incidence ratio when compared to age-matched sex population controls. And so as you see here, no huge surprises. Hodgkin's, Ewing sarcoma, medulloblastoma, neuroblastoma, these cancers were most commonly associated with developing a secondary cancer afterwards. All four of these, radiation is one of the primary treatment modalities as well, and they get a great deal of alkylators in addition. All diagnoses kind of fall right here in the middle, where you see about a 6-fold increased risk of developing secondary cancers. And as I mentioned, radiotherapy also causes significant morbidity. As you see, secondary neoplasms, malignant neoplasms, and non-melanoma skin cancers, the incidence is all increased with radiotherapy. Now, what kind of cancers do these patients develop? As you see here, I've also looked at the standardized incidence ratio and the number of cases observed in the CCSS. And in terms of increased risk, osteosarcoma takes the cake. This is common in patients who have been radiated in that area. Also, we looked at breast cancer, where we see the most cases of breast cancer in our survivor follow-up. However, breast cancer in general is very common, so compared to the general population, not quite as much of an increased risk. How good are our patients and doctors, I guess to some extent, at screening and surveying for these neoplasms? And so this is based off of self-report from these survivors, and so it has to be taken, I think, with somewhat a grain of salt, but in this study, patients were divided into average risk and high risk groups. Average is kind of everybody else, and the high risk groups were defined as follows. So groups at high risk for breast cancer receive radiotherapy greater than 20 gray to the chest. The Children's Oncology group recommendations, is typically what we follow, recommend annual mammography at either the later of 8 years post-therapy or at 25 years of age. For colorectal cancer, Similarly, radiotherapy greater than 30 gray to the abdomen, pelvis, or spine, or anywhere with the bowels in the radiation field. COG recommendations are for every 5-year colonoscopies at starting at age 35. And skin cancer risk. So anybody who's received radiation therapy at any point is considered in the high-risk group. And current recommendations are for an annual skin exam. However, survivors at high risk are poorly compliant with this, and only about a quarter of them have had this done at any time. And when we look at our screening and surveillance habits in our low-risk and high-risk population, so the low-risk population, interestingly, seems more compliant. They seem to do better. And you see the majority of patients obtained a mammogram and a pap smear at their appropriate time within recommendations. However, the high-risk group seem to fare much worse, believe it or not. And in fact, almost 37% of patients who should have gotten a mammography haven't. And so this is, or should have gotten a mammogram. So this is clearly a group where the energy can be focused. Even worse was colonoscopy surveillance, and close to 80% of patients who should have had a colonoscopy by current recommendations have not. So clearly some room for improvement in our higher risk population, which is kind of ironic to me. Now, can we improve compliance? I think we could probably talk here all day about trying to get patients and, to some extent, physicians to comply with recommendations, and this is a huge area of research in many fields. When the CCSS looked at Hodgkin survivors, this was a prospective one-arm study on patients who had not had their screening mammogram or echo in the prior 2 years. And what was done, a one-page care plan with recommendations was mailed to the patient, as well as the PCP being contacted with recommendations as well. They also provided a web-based information center for patients and doctors to utilize, and then they looked at outcomes at 6 months. So 41% of these patients actually went ahead and completed a mammogram, 20% did an echo, and 29% of survivors actually visited the website to begin with. So hard to say in a one-arm study if this would be better or worse than a possible control group, but seems to me maybe a step in the right direction, but this is clearly an area of importance that needs to be addressed in the future. So if you're looking for good resources and recommendations regarding secondary malignancy screening, for the average risk population, I'm sure you probably use this in your practice, the American Cancer Society and the U.S. Preventive Services Task Force have pretty good links to that. However, if patients are in a higher risk group, www.survivorshipguidelines.org is really the authority on monitoring for late effects in the pediatric population. In fact, you can download it for free online. It's about a 200-page PDF file as well, and it gives detailed recommendations, and it's updated regularly. It's probably the best resource out there for managing these patients, and I'll give you that link again at the end of the talk. We pretty much tell every one of our patients to wear sunscreen. As you saw, the incidence of melanoma and non-melanoma skin cancers alike is much higher. Unfortunately, we don't know how well these interventions really work. We recommend close surveillance and close follow-up and these measures, but we're not sure how well that helps in the long run. When we look at cardiovascular toxicities, to change gear here to kind of single organ systems, there are two main treatment modalities that we use that can affect the cardiovascular system, and that's anthracycline chemotherapy and radiation. Anthracyclines, you may know from the right panel here, doxorubicin, daunorubicin, idarubicin, epirubicin, mitoxantrone, they all have this quinone moiety in common, and they're very active anti-cancer drugs. The most commonly used in pediatric cancers in AML, ALL, Hodgkin's, non-Hodgkin's lymphoma, osteosarcoma. They're very commonly used, and on a subsequent slide we'll mention that close to half of our pediatric population will receive anthracycline drugs during their therapy. Their mechanism of damage occurs when they attack the heart and cause reactive oxygen species, and also can interfere with iron scavenging as well. They directly end up damaging building blocks of DNA, intracellular macromolecules. They also directly damage cell membranes, and what this leads to is a pretty bad cycle of where you get premature apoptosis and then resulting fibrosis thereafter. When we look at a mouse heart, for instance, treated with doxorubicin, as you can see here in the lower panel, this extensive fibrosis right in here that takes place with doxorubicin treatment. The types of toxicity are ranging far from subclinical toxicity to fulminant heart failure. What we're learning more about now is that probably there is no safe dose of these medicines, and there is subclinical damage that occurs in most patients. The toxicity can be acute, but more often this is late onset and progressive. The resulting cardiac defect is depressed contractility, increases afterload, and then you get eventual left ventricular dysfunction. And that's pretty much the extent of my cardiology abilities at this point. So actually what's interesting is that these kids more often than not have kind of a honeymoon period, and so shortly after their therapy, their ventricular contractility and mass is actually pretty decent. However, this is years after therapy, and these are ALS survivors treated with dox. That's where we really see some bad things start to happen. Sadly, only 52% of patients treated with dox actually know that, and 30% for dono. So when kids come into our clinic, we review this every single time. As far as non-cancer mortality, cardiac disease is the #1 cause. So I really focus on cardiac #1. I'm talking about organ toxicity in our late effects clinic. And aside from left ventricle problems, there's other cardiomyopathies, pericardial disease, coronary artery disease, and conduction problems, as well as valvular problems as well, that we can see. When the CCSS looked at this compared to the sibling population, we see a incredibly increased incidence of congestive heart failure, MI, pericardial disease, and valvular anomalies. And these are in all comers. Also, the effects seem to be worse in younger patients, and we take that into account when we're stratifying them for screening. 0 to 4-year-olds clearly fare worse, and then age thereafter seems to fare better. So increasing age when you're exposed to these types of things seems to be protective. So the anthracyclines also, their toxicity, at least in measurable things, seems to be dose dependent. And as you see here, this green line shows patients who receive more than 250 milligrams per meter squared versus less than here in the red line. And there's a significantly increased risk of congestive heart failure cumulative incidence. The Europeans actually have similar data as well, showing a relative risk of almost 8 in patients who receive more than 300 milligrams per meter squared of anthracycline. And this is kind of, for at least for many years, has been kind of a magic number in pediatric oncology for doxorubicin dosing. And so it's at this level where oftentimes we'll employ cardioprotectants, or what we think may be cardioprotectants, as I'll go on to talk about, and we'll really start to get wary and watch a little bit closer. The incidence out to about 10% actually, out to 20 years. In some patients, we actually go way above 300 milligrams per meter squared, and as you see, this is a very harsh dose response curve. Some of our patients on older AML protocols, awful sarcomas, they can get upwards of 450 to 600 milligrams per meter squared, and so these kids we have to watch really closely for toxicity. So as I mentioned, radiation is bad. This relationship with cardiac toxicity is also dose responsive, as you see here. Patients who receive more than 35 grays of radiation have a much higher incidence of congestive heart failure, myocardial infarction, pericardial disease, and valvular problems. And it seems to be dose responsive as well. So what do we recommend? Well, we have a pretty specific protocol, which I'll show on the next slide, for monitoring with echocardiograms. And it is recommended to get a fasting lipid profile every 2 years. As far as how to prevent or treat this, One of the mainstays of modern pediatric oncology has been to try to reduce therapy in lower risk groups, and that's one thing that we're doing in trying to reduce cumulative dose and radiation. There are anthracycline analogs in the work and liposomal preparations that would hopefully spare the heart. These are very cutting edge. Cardiologists always work pretty closely with us in this regard. Desoxane is thought to be a cardioprotectant, and we give it to patients who get high levels of anthracyclines. However, its efficacy is hotly debated in the community. Also being looked at has been prophylactic use of ACE inhibitors and beta blockers. The outcomes of these interventions, it's controversial and not clear as well. And kind of on the forefront is the use of serum biomarkers, so BNP, secreted microRNAs, things like that. And actually, last week's issue of one of our main journals discussed this. So that's kind of on the forefront. Are there earlier ways to detect cardiac damage prior to seeing echocardiographic abnormalities? And so this is a big area of research. Also, Dr. Lipschultz, who I've cited several times here, he's kind of the authority on this topic, and there is an association actually between the hemochromatosis gene defect, HFE gene, and susceptibility to cardiac toxicity, and thought to be due to the iron scavenging pathway. So more to come on that. The echocardiogram recommendations, these are available in survivorship guidelines, and so they're risk stratified based on age at treatment, the dosage of anthracycline, and the use of radiotherapy. So next up, I'd like to talk about pulmonary toxicity. The treatments that we use that primarily cause this are bleomycin and radiation. Cancers typically affected from the pulmonary standpoint are Hodgkin's first and foremost, but also germ cell tumors, patients who have received bone marrow transplant, spinal and mediastinal tumor patients, and then anything where you've got a pulmonary metastasis certainly can be affected. The mechanism of damage can be twofold, so you get cytokine release, and then septal fibroblasts increase their collagen production. They lay this down, the lungs become more fibrotic, and then subsequently you get functional impairment. And in our younger patients, treatments also interfere with lung and chest wall growth. So as you see here, the blue line indicates the relative risk of various pulmonary complications relative to the general population, and the prevalence is shown as the bars on the right. So these patients are at the highest increased risk for having abnormal chest wall, recurrent pneumonias, and lung fibrosis. However, the most common thing that we see in these patients are bronchitis, recurrent sinusitis, exercise-induced shortness of breath, chronic cough. These are actually more common complaints that we see in the clinic. And as expected, radiotherapy also kind of hits the lungs twice as hard as well. And so, as you see here, patients who have received pulmonary toxic chemo and radiation, or both, seem to have fare much worse in terms of lung fibrosis, chronic cough, exercise-induced shortness of breath, and pleural disease. These patients will often complain of cough, exercise intolerance, shortness of breath, and typically in patients at risk we obtain a baseline chest x-ray and pulmonary function testing. And in fact, the abnormality seen on this is quite high, especially in asymptomatic patients, so important to do a good screenings and to intervene early. Once again, Hodgkin's survivors fare fairly well with this because they get both, fairly poorly, I mean, they get both bleomycin usually and usually get radiation to the chest in many circumstances. Basically, we do try to limit our toxicity with our therapies as much as possible. And in the primary care realm, smoking, counseling, and avoidance is paramount, because you can only imagine the damage that smoking could do on top of these other comorbidities. And so we do a fair of that in our clinic, but I would argue that many of you in the audience are much more adept at doing that, and so that's critical. Evaluations prior to anesthesia are also something that we do. I'd like to change gears a little bit here to neurocognitive impairment in cancer survivors. The treatments that result in this most often are brain surgery, cranial irradiation, of course, intrathecal chemotherapy, which we give for our leukemias and some lymphomas with methotrexate, Aracy, and steroids, as well as systemic steroids actually too seem to play a role in this, and patients undergoing transplant. Once again, most commonly this is seen in brain tumor patients, as well as those with ALL and non-Hodgkin's lymphoma. The pathophysiology is really multifactorial here at both the microscopic and macroscopic level, and so there's some degree of radionecrosis that can occur with radiation. You can get a leukencephalopathy, you get angiopathies, you get sclerosis of the cerebellum, spinal cord dysfunction, surgical morbidity, of course. You get epithelial and white matter damage, and then there's some degree of immunologic dysregulation that can underlie all of this. Interestingly, the impairments don't seem to occur by losing prior skills, and in fact, these patients typically lose the ability to acquire new skills. Also interesting is that this is independent of the amount of school missed. And so, most of our patients will miss some degree of school, but their learning impairment doesn't seem to be related to this at all. Also important is that this occurs many times after therapy, 1 to 2 years after, and it can be progressive. So there are a number of risk factors for this radiation, of course, and young age of radiation. Also, female gender, the time since treatment, and potentially some genetic polymorphisms may play a role in this. The types of deficits are quite wide-ranging as well. Attention and concentration problems are extremely common in brain tumor survivors and up to 40% of ALS survivors. There are deficits in processing speed, visual perceptual skills, especially for those who have a posterior fossa brain tumor. There's defects in executive function and memory, especially in brain tumor survivors, and ALS survivors to a lesser extent, but these patients often require special education in school. There's also defects in language. ALS survivors actually who have been radiated to the brain with more than 24 gray show 10-point decrease in IQ. So this is clearly not benign. Medulloblastoma survivors have been shown to fare even worse potentially, and the amount of patients with an IQ less than 60 out to 10 years is almost half. So these patients can be severely neurologically devastated, especially when they're radiated at a young age. Brain tumor survivors also don't complete high school as much. Only 18% did not complete high school. There are a number of recommendations that we have in this realm, and our clinic is pretty aggressive in trying to address these. We do a baseline neuropsych assessment. We do this in conjunction currently with the University of Iowa, but we are very close to starting this up at Blank, and we're finding a pretty big benefit to doing this because they can accurately address where these particular deficits are taking place. And a number of our patients, at least anecdotally, seem to have benefited from changes made in the classroom as a result. It's also important to assess this yearly and continual over time. As I mentioned, the defects are often progressive, so this is not a static phenomenon in any way. There's actually no indication also, in case you're wondering, for routine neuroimaging unless there's a clinical concern. What the PCP can really help with in this arena is basically being aware of this number of problems, and I'm sure many of you already asked about school and education and things of that nature, and then help guide parents toward the appropriate evaluation at the outset. Also critical is that these patients have every right for intervention. So the American with Disabilities Act has kind of paved the way for this, but we do a really good job getting patients IEPs and different education plans in the classroom. Also, the PCP can be very valuable in providing medical documentation regarding the particular defects in getting the right services. Always good to check for hearing and vision defects, not because that's just a standard approach, but also because our patients have these comorbidities as well. Many of them, which I won't talk about too much today, but many of them do have visual and auditory impairments from their therapy. We actually have a school liaison in our clinic as well who does a great job at working with our schools to get our kids the appropriate services that they need in the school reentry plan if necessary. What we don't know very well is the large population-based studies of how well this works in terms of cognitive remediation or other pharmacotherapies like ADHD meds and things like that, how well they work in this population. There's a good resource at the American Childhood Cancer Organization if you're interested. Next up, growth. So this is a commonly addressed topic in the pediatric clinic, no doubt. And chemotherapy and radiation and all the stuff that we do can severely affect both linear growth and body composition. Craniospinal radiation, of course, is our biggest culprit, and the impairment is the etiology is multifactorial in that you can get a growth hormone deficiency by injuring the hypothalamic pituitary axis. You can get direct arrest of vertebral body growth being radiate during these periods. It can affect the timing of puberty. And in these patients, catch-up growth is not quite as likely. When we treat patients with certain chemotherapies, the effect does appear to be more transient, and there is possibility for catch-up growth. These patients who get high-dose prednisone and methotrexate, in particular our ALL population, this can affect them. We do occasionally treat with growth hormone in patients who are growth hormone deficient. It appears to be safe, however, the efficacy, once again, the jury is still out a little bit. So as far as what's associated with short stature in the brain tumor population, patients who are diagnosed at a very young age, patients who are radiated, and patients who are radiated and get chemotherapy. So this is no huge surprises here. When we look at the mean adult height of brain tumor survivors, males appear to be about 10 centimeters shorter on average than population control norms, and females close to about 8 centimeters shorter. So clearly a statistically significant difference. Patients who have survived ALL also have significant growth impairment. There's about a 12-fold risk of having short stature in this population. This is associated with chemotherapy and prepubertal diagnosis, cranial radiation, and female gender. So here we look at our mean adult height again versus our sibling controls, which is the bar on the left. And as you see, patients who have received chemotherapy followed by escalating doses and location of radiation appear to fare worse in height overall. So obesity is also common in this population, and if anybody has any suggestions on how to help with this epidemic, I'm open. This is clearly a huge public health challenge facing all of America, not just our pediatric cancer survivors. Of higher concern is that obesity poses an additional risk factor because these kids do have other comorbidities. There's a 50% increased risk in female leukemia survivors of being obese, and 20% in males. Interestingly, predictors of obesity in our childhood cancer survivor population, the number one association actually was patients who are on paroxetine. So in terms of psychotropic drugs, this is potentially an intervention that one could make to use an alternative drug that is not associated with this. And actually they looked at the majority of psychotropic drugs, and paroxetine was the only one associated with increased risk of obesity. Patients who are less physically active or less able to be physically active, of course, this makes sense. Patients who have had the hypothalamic pituitary axis radiated, age at diagnosis between 5 and 9 years were also predictors of obesity. Patients who engaged in more physical activity, this is not rocket science, seem to fare better. And also patients who had a medium amount of cancer-related anxiety seem to do better. So basically, the recommendations are as follows, and this is, I think, done in clinics everywhere, is close tracking of growth and weight on CDC curves. We definitely recommend obtaining the appropriate lab evaluations when necessary, and that can be growth hormone, that can be lipid panels. I tend to yield to the generalist on that topic. Growth hormone, like I said, its use is controversial, but there is some success reported with replacement in patients who are deficient. If you are good at counseling on diet, exercise, that goes a long way. However, I think we still have a lot to learn about how to effectively treat this population. I think one question that gets asked quite often in our clinic, and I'm sure yours as well, is am I going to be able to have kids in the long run? And this is hardly a topic that gets addressed with a 4-year-old at the time of diagnosis. And honestly, there's more pressing issues at time. And as an aside, our patients can experience a great deal of anxiety and are a little bit unaware when they come in about what we're going to hit them with in the late effects clinic, about all the different possibilities that could happen in terms of side effects of therapy. So fertility is always a big question. In terms of pregnancies from male survivors, there is a decreased likelihood of producing a live birth. There's a 24% reduction in fertility, in fact. And this is primarily due to alkylators, first off, that they decrease spermatogenesis. Kind of our magic number, so to speak, for dosage is 7.5 grams per meter squared. Beyond this, the likelihood of infertility being reversed is very low, but not zero. And the alkylator toxicity seems to be worse in the younger patients. Radiation is also the other culprit here. It can cause germinal loss, decreased testicular volume, and decreased sperm production. The radiation effect is dose dependent. Also, some of these patients have orchiectomies. They have a germ cell tumor, or sometimes it's resected, in cases of leukemia. Can have effects on puberty as well. When we look at female survivors, they also have a decreased likelihood of having an intrauterine pregnancy. It's most often associated with hypothalamic pituitary radiation, but can also be associated with ovarian and uterine irradiation, and that relationship also is dose dependent. Patients who have received high-dose alkylation, as well as cyclo or other chemotherapeutic agents like lomustine, have a decreased likelihood of being able to become pregnant. As far as the offspring go, this is also a very common question. Certainly the late effects, there are many variables going into this, and I'm not going to touch much on the teratogenicity of chemotherapy, which is pretty well documented. But patients who have been irradiated, in addition, they can also have pelvic abnormalities, which can prevent successful pregnancy. So they can cause low birth weight, prematurity, miscarriage, perinatal complications. And probably the biggest take-home point here is that this has been looked at under many different circumstances, actually, and there appears to be no increased incidence of malignancy or mutagenicity in the offspring of these survivors, except when there's a known genetic syndrome in the family already. There's no increased incidence of congenital malformations, single gene defects, cytogenetic problems, and so that's always a common question that we ask. Now, we can go on about what's being done in the high throughput genomics field about perhaps slight increased risk in certain familial predisposition that may be slightly greater than the larger population, but as far as the thousands of patients who have been looked at to date, does not appear to be any increased incidence of these malformations. As far as management goes, we always ask about libido and fertility and developmental screening. That's important. Many of our patients will sperm bank if they are developmentally appropriate at the time. And this is always a challenging conversation to have at diagnosis when you're diagnosed with a cancer and you have that 14-year-old and you're talking with them about what's going to happen several years down the road. But we do that, and then when the time comes, semen analysis and a fertility evaluation is the next step. And I always say nothing's 100%. We see many patients who said, my doctor said I could never have kids, and then, whoops. So anyhow, this is no excuse to not still practice safe sex and do appropriate reproductive counseling. A little bit beyond the scope of my discussion today, there's many other effects of our cancer treatments, and so skeletal, auditory, ocular, Many patients have single organs, and so these are other things that we address in the late effects arena, but I'll just kind of gloss over just a little bit today. I'd also like to just touch briefly on psychosocial outcomes in these patients, and this is probably something that we don't do a great enough job addressing, and that these patients have a much higher likelihood of never being employed. In general, they have lower income, and about 10 times as likely to have difficulty obtaining insurance. So that's also one thing we stress is continuity of insurance throughout, because these patients will have a real hard time getting it in the future. They're also less likely to get married. They have decreased psychosexual functioning, so they go on dates at later periods of their life. Their development in that arena is usually delayed. These kids typically have fewer friendships. They have a higher incidence of depression, anxiety, and stress. And these are all things that that we see, but probably, if I'm going to address during a visit cardiac disease versus, stress, I want the kid to get the echo. And so, this is something that we need to probably do a little bit better job of. So to just summarize briefly here, pediatric cancer outcomes have improved tremendously over the years. And the result, while it's great, has resulted in a unique survivor population with a high incidence of late effects, a wide range of late effects, and they can often be very severe. It is hopeful that the incidence and severity of these effects can be modifiable by us. We have a growing knowledge base, but as you can tell by my talk, we don't have a great handle on how well our interventions are working at this point. So this is a huge area of research coming up. To really emphasize optimal care of these patients, incorporate patient education and a multidisciplinary approach with the oncologist, the PCP, specialists, psychologists, nurses, all working together. We'd like to just take a minute to introduce our late effects team at Blank Children's. So Dr. Schwalm, she's the director of our late effects program, and Lori Phillips, she's our late effects coordinator and school liaison. So she does a great deal of work in calculating chemotherapy dosage and talking with schools and putting together IEPs, and so she's a very valuable part of the team. We have a comprehensive clinic, as I mentioned, and this was started thanks to a Hyundai Hope on Wheels grant we obtained last year, and so that's been a tremendous boost for the care of these patients over at Blank. We do provide all patients with a treatment summary. They should have that in their hand and should hopefully be making its way to your offices. I will show you in a second actually what one of them looks like, so you can keep your eyes open for it. Here we make sure they adhere to appropriate screening and management, and we are the type of people that follow up and call to make sure they got their echo. Why are you missing this appointment? Did you go see your doctor about your high cholesterol? That type of thing. And we work pretty closely with folks in the community. Like I said, we work with U of Iowa in neuropsych testing, and we're starting to do some fairly soon over at Blank. Like I said, we work with schools, and we're actually conducting some research as well on late effects. Right now, we're in the process of recruiting a pediatric psychologist as well, which was obtained with another Hyundai Hope on Wheels grant, which was awesome. On the horizon also is an adolescent young adult clinic. As you might imagine, it can be a little awkward for a 29-year-old man to come in and be seen with newborn babies and 5-year-olds running around. So I think this will cater and probably improve compliance in our young adult population. And we've established a research database, which is ongoing. Here's an example of our treatment summary here. Patient demographics, talks about the cumulative dosages of medications, therapy complications, surgeries. It goes on to actually go on to give recommendations as well for those of you out there who don't have time to look up the survivorship guidelines, and can go right here to a pretty easy summary for that particular patient. And then the last page is also cumulative chemotherapy doses as well. And so Dr. Schwalm is not only a late effects person, we actually all kind of share in the duties. We have our own clinical areas of interest as well, and we're happy to be a resource with you for late effects or otherwise, and we're happy to be emailed or called or whatever, so we're there to help you out. We have a great multidisciplinary team as well with nurses, social workers, research assistants, doctors, everybody. So, and last, I would like to end, certainly the patients are their own great story.
My name is Jonathan, and I'm a 5-year lymphoma survivor. I'm Nick, and I'm a leukemia survivor.
I'm Jonathan O'Leary. I'm a T-cell leukemia survivor.
My name's John. I am 11 years out since my diagnosis, and I had non-Hodgkin's lymphoma.
So I've also compiled these references for you at the end, many of the ones I've spoken about in this talk, as well as many of the papers that I've cited regarding the primary care approach to cancer survivors. But once again, we're always happy to be a resource for you, and thank you once again for having me, and I'll open up for any questions.
A little bit unrelated to this talk, however, very related to the care of your patients. Do you want to make any comments on the national drug shortages, especially those drugs that are very much used in pediatric oncology?
This has been a huge source of frustration for us, and I don't think there's any end soon. I'm relatively new to the field. I've only recently finished my fellowship, but I think since I started, there's been constant concern about drug shortages. One day it's doxorubicin, the other it's methotrexate. Our Children's Oncology Group website lists these frequently. At Blank, we've had a number of ways to fortunately combat this. Number one, we're actually pretty well stocked in terms of chemotherapy drugs, which has been good. So we haven't had to deny or change therapy on anybody, which has been great. And our pharmacists really stay on top of that so we can usually weather these temporary storms. Fortunately, the methotrexate situation has seemed to be resolved. The other thing we've done is also, when we give intrathecal chemotherapy, for instance, with methotrexate, we've been able to, batch kids on certain days so we don't waste any of our supply, and so that's been one strategy that we've used as well. But it's unfortunate because, as I mentioned, only 13,000 kids a year get cancer, so for many of the manufacturers, this is not the most lucrative field to be manufacturing for. So it's a source of frustration. We do our best to deal with it.
In the case of neuroblastoma, do you have any recent information on the tendencies of someone who is to be born with a neuroblastoma and mature into a mature tumor?
So neuroblastoma is a very interesting disease because there's these low stage 1 and 2 neuroblastoma that usually a little paraspinal mass of some kind, many times goes away on its own. Usually these are in little babies, and chances are they're probably born with that in some capacity. However, the link between what goes on at that point and fulminant stage neuroblastoma, stage 4, bone metastasis, it's a completely different entity. And as far as is there something that connects those? Is there a transformation that goes on? Are these two completely separate entities? I don't believe it is known, at least to my knowledge right now. As far as being born with cancer, that's a whole other talk, because in pediatric cancer, it's not like adults where so much of it can be environmental. And in kids, there's some type of genetic change that takes place. In many of our leukemia patients, there very well may be some early insult in utero that occurs, and we don't have a great handle on that yet. So more to come.
Let me just ask you, because of the sequela and these years of post-chemotherapy or radiation therapy, is there pressure on current protocols to reduce? I mean, how much pressure is there? I mean, there's got to be pressure, but where does it come from?
There's a great deal of pressure, no doubt, and science has taken us a long way in the last 20 years or so. If you saw in my graph in my second slide, I think you saw that Hodgkin's line was kind of stagnant, around 90% cure rate. Well, basically, the goal on Hodgkin's therapy, for instance, has been to reduce therapy. Is there a subgroup of population that we can spare radiotherapy in and still keep outcome the same. So the two goals, maximizing cure and minimizing toxicity, are at the forefront. Standard risk ALL patients, we've been able to back off considerably in therapy to prevent toxicity in the long run. One of the biggest advances that has been made has been in technology. So we are learning so much more about the predictive capabilities of the cytogenetics of these disease, as well as host factors that have been able to enable us to risk stratify patients better to either augment or reduce therapy. It's actually a really exciting time. With our advances in flow cytometry and PCR, the amount of disease that we can detect in leukemia, for instance, is very, very minimal, and has turned out to be the most important predictive factor in treatment of ALL. So you're right, there's a huge pressure, and it's always a constant battle, weighing the effects of your treatment versus the possibility of cure and being able to live with that. So, yes? So that's a huge topic, because there's been a lot reported in recent years about radiation exposures from CTs and causing a primary malignancy in some. In our patients, if they have a rare genetic syndrome where, due to easy chromosomal breakage or something like that, we will do our best to spare CTs. I do not know of any data, though, about subsequent imaging or imaging done during therapy. I mean, the average kid with neuroblastoma probably gets like 50 CTs during their therapy. So I don't know how much that plays a role, honestly, either scans during on-treatment or off-treatment afterwards, how much of an increased risk that poses, I don't know. I think this is definitely a good population, though, to try to limit those types of imaging. So. All right, thank you again.